Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine Podcast. I'm your host, Yaron Ivan, Pediatric Emergency Medicine attending in Orlando, Florida. And today we're continuing some discussions, some important discussions with some very important rules that help us communicate better with each other and do what's right for our patients. Rule number 60, own your equipment, own your ER. So sometimes I come to the ER on an, let's say, afternoon shift, and it's very, very busy. So really, the sooner I get to business, the better. Patients are already waiting. My colleague is dying to go home. They're exhausted, which I understand. So let's get started. I sit by the computer, and it's not working. It's not loading. It's frozen. Something wrong. And when that happens, in the past, sometimes I get a reaction, something like, "Hey, Dr. Ivan, no, this computer is not working. It hasn't worked for 3 days." Well, in my mind, a computer in the emergency department is integral part of our equipment. I cannot do anything without the computer. I can't see the patients. I can't see their vitals. I can't put orders. Useless. And if somebody saw that this computer has not been working for 3 days, how come it's still not working? How come no one made a phone call to our tech support people or our computer people, as I like to call them, simply put, and put in a request to replace it, fix it, address it? In my mind, if I come to the ER and something is not working, I can address it. Either fix it myself, unlikely, or call someone. There's always someone who can help. In my hospital, we have a team called the Red Shirts. They take care of everything. Everything that has to do with a computer not working, software not loading, etc., etc. You make a phone call, they come. So if you see something that doesn't work, speak up and make it happen. And again, it doesn't mean you have to fix it yourself. There's always someone to talk to. Another good example is if I walk in the room, all excited, see the patient, and the patient is complaining of ear pain. Well, guess what? Now I have to use the otoscope to look in their ears. I grab the otoscope, and lo and behold, it's not working. When I come out and I ask, "Hey, did anybody know that the otoscope in room 16 was not working?" And I get something like, "Oh yeah, I think the light bulb is off, Dr. Ivan. It's out. It's been out for a day or two." Well, if you know it's been out for a day or two, and an otoscope, and again, is an integral part of our work, say something. There's a charge nurse. She's always happy to help. She can get a new light bulb. I don't even know how, but they know how to replace it, and it makes it happen. And it works. So own your equipment, own your ER. If you notice something is broken, call someone, take care of it. Rule number 61. Before discharging a patient who was recently operated on, speak to the surgeon. This rule is very important, and it kind of stems from other rules. For example, know what you don't know, or be professional to your colleagues. So if I see a patient, let's say, that had a simple appendectomy 3 days ago, and he's coming in with abdominal pain. He looks great. Seems like maybe it's some constipation, maybe secondary to some ileus post-op. He can jump. He has no peritoneal signs. He has no fever. I'm not concerned about an abscess. And I think he's ready to go home. At the very least, I call the surgeon. And remember, every patient needs an assessment and every patient needs a plan. I say something like, "Hey, so-and-so surgeon, your patient so-and-so is here. He had appendectomy 3 days ago. He comes in today with abdominal pain. He looks great, no vomiting, no red flags. His exam is very benign. I think most likely constipation secondary to ileus. I certainly don't think he has an abscess or any other post-surgical complications. And I think he's ready to go home." So remember, make an assessment, make a plan, but you have to call the surgeon who recently operated on him just a few days ago, even if you don't think it's surgically related. Reason being, it's sort of a respect thing. So if a patient was operated on, I think it's a respectful thing to call the surgeon and run the plan by them. They're always happy to help. And it's also stems from the fact that I, as a non-surgeon, have to understand that I don't know what I don't know. Maybe there's some complication post-appendectomy that presents in this manner, mildly, with no red flags, etc., etc. Maybe it's someone that the surgeon is actually going to want to come and see in the ER. They often do that, which is great. So when you see a patient that was recently operated on, you really should speak to the surgeon before discharge the patient. And in the past, I must say, I've gotten some surprising responses from the surgeon, something like, You know, Yaron, this actually sounds like complication X, which I sometimes see post-op. Why don't I come see the patient, or why don't you admit him and get some labs and we'll see him in the morning? I have to know what I don't know. I'm not a surgeon, although to me, medically, the patient looks well. I must recognize that I don't necessarily know all the post-op complications for all the surgeries that my patients go through. And there's someone who does. He's called a surgeon, and he's a great guy. Why don't we call him, do the right thing for the patient before we send the patient home? So before discharging a patient who was recently operated on, speak to the surgeon. Rule number 62. You go to Midas, you get a muffler. Think hard before you ask for a consultation. This is an important rule to think in mind, especially when you speak to consultants. It's also related to anchoring and bias, two things that we face in our profession all the time. I'd like to give a shout out to Dr. Rick Saladino, one of my mentors, for the example of how he uses that rules and how it comes to play. So let's say you're evaluating a 60-year-old with swollen and painful knee. The patient has no recent history of trauma, no fever, nothing else, no intercurrent illness. The knee exam demonstrates a large effusion, moderately warm to the touch, and range of motion is mildly, maybe moderately limited due to 5 out of 10 pain. There is no evidence of injury to the knee, to the skin, nor is there a rash. If you anchor the diagnosis of septic arthritis, you have gone to Midas and you'll get yourself a muffler, meaning that you are at risk for focusing on that diagnosis, which indeed is a worrisome diagnosis, to the exclusion of consideration of other important diagnoses, such as maybe something like Lyme arthritis or first presentation of any rheumatological disease like JIA, or maybe a bleeding disorder or bone cancer. Another good example for this rule is if you rely on the opinion of an orthopedist consultant for this child, you will probably again be subject to a different form of anchoring. That is, consulting the orthopedist person for such a patient will likely yield what they know, what they worry about, what they are best at, something like septic joint at the top of their differential diagnosis. More than likely, and without trying to be critical of our orthopedist consultant, they are fantastic, you will be asked to obtain blood culture and a CBC and inflammatory markers, maybe imaging of the knee. Likely the plan will be something invasive like a joint aspiration. You go to Midas, you get a muffler. In this case, that means that you ask an orthopedist specialist, you are at risk for getting an orthopedic answer. This is not a critique, but ortho doctors are worried about septic joint. That's what they do. That's what they worry about. That's what they are best at. They want to go to the OR. That's how they think about their patients. In their mind, knee pain is a surgical problem until proven otherwise. So when you ask for their advice, that's what you'll get. Another good example for this rule is when you consult a plastic surgeon about a dog bite. From a pediatric emergency standpoint, really dog bites should not be sutured. They are very high risk for infection. I usually irrigate those the best I can. I provide antibiotics, maybe even IV, and admit the child, but I avoid closing dog bites because of the risk of infection. However, if you consult a plastic surgeon about a dog bite, he most likely will encourage you to suture it or will want to suture it himself because plastic surgeons, being plastic surgeons, are more worried about scarring and cosmesis. So in their mind, every laceration should be sutured. They are not as concerned about infection, cellulitis, etc., as we are pediatric emergency doctors. So when you go to Midas, you're going to get a muffler. Rule number 63. Parents, families need to know 3 things upon discharge from the ED. What is the problem, what to do for the problem, and what to come back for. This, guys, is a very, very important rule to communicate to parents. It basically boils down to good anticipatory guidance. If I diagnose a URI in the ER, I make sure the parents understand what is a URI and what it causes, what to do for it, not a whole lot in the case of a URI, and what to come back for. So a good example is bronchiolitis. Mom and dad, just so you know, little Johnny has bronchiolitis. The way I think about bronchiolitis is if the cold is up in the nose and the throat, pneumonia is down in the lungs, bronchiolitis is kind of in between. So it's a viral illness that causes a lot of mucus in his lungs, and that's why he's wheezing. Sounds like asthma, but we know now asthma medications do not help. What you can actually do, mom and dad, is drop some saline in his nose or spray some saline in his nose and suction him. That's the only thing that has been shown to help kids with bronchiolitis a little bit. Now, that may or may not help, so I certainly want you to come back. If little Johnny is not taking the bottle and you're not seeing wet diapers, if you think he has difficulty breathing and you suction him and it provides no relief, feel free to come and tell us and we'll take care of it. Some kids with bronchiolitis certainly have to come back to the ER or even stay in the hospital. So that's kind of a good example. I told him what the problem is, I told him what to do for it, and I told him exactly what to come back for. Another good example is when I drain an abscess, I always make sure they understand there's a possibility I didn't do a great job draining it, and despite my antibiotic prescription that I'm going to give, the patient may worsen again. So mom and dad, little Johnny has an abscess. It's basically a collection of bacteria that was underneath the skin. I made a little incision. I think I got all the pus out. I irrigated it. I'm going to give you some antibiotics, which should help. I want you to put the area in a warm soapy bath so the area continues to drain, and you can also apply some antibiotic for it. But just be aware, all those things sometimes may not help. So if that area becomes red again, very painful, if you see pus coming out, you should certainly come and talk to us and we can take care of it. So again, parents, families need to know 3 things upon discharge from the ER. What is the problem, what to do for the problem, and what to come back for. This is just kind of recognizing maybe things will not work the way you want them. So make sure your parents are educated so they know what to come back for. And that is it for today, guys. Thank you very much for listening. I hope you enjoyed the show. As always, feel free to submit some feedback through the website, episodes you want to hear, topics you want to discuss, or anything you have to say. Love to hear from you. I hope you like the little outro I have here, and I hope you have a great day. Have a good day. Thank you, guys.